The prostate is both an accessory gland of the male reproductive system and a muscle-driven mechanical switch between urination and ejaculation. Anatomically, the prostate is found below the bladder, with the urethra passing through it. It is described in gross anatomy as consisting of lobes and in microanatomy by zone. The zones are transitional, peripheral, central and periurethral zones. Androgen is a group of sex hormones that give men their male characteristics. A major sex hormone is testosterone, which is produced mainly in the testes. Prostate cells need androgen for their growth and function. Disorders of the prostate include enlargement, inflammation, infection, and cancer. Depending on the growth mode of the cancer, we distinguish two types of cancer cells, namely, the androgen-dependent cancer cells and the mutated androgen-independent cancer cells. Prostate cancer is a major public health concern in the United States, with 248,000 new cases annually, and 34,000 deaths. In metastatic prostate cancer, 5-year survival is only 35%. When untreated, or when even one cancer cell is left behind, it can grow and divide to become a new tumor. A new tumor can start to grow in the same area of the body where the cancer first started, or the cancer may have spread through the blood or lymphatic system to another part of the body, where it grows into a new tumor. Metastatic cancer is commonly called stage 4 cancer or advanced cancer. Treatments of metastatic castration-resistant prostate cancer include ADT, enzalutamide, ENZ, in combination with chemotherapeutic drugs, and current clinical trials include also cancer vaccines, sipuleucel T, SIP-T or Provenge, and immunotherapy, anti-CTLA-4 or ipilimumab, primary checkpoint inhibitors, anti-PD-1 or nivolumab. Enzalutamide, sold under the brand name Xtandi, is a taken medication which is used in the treatment of prostate cancer. It is indicated for use in conjunction with castration in the treatment of metastatic castration-resistant prostate cancer, non-metastatic castration-resistant prostate cancer, and metastatic castration-sensitive prostate cancer. It is taken by mouth. Ipilimumab, sold under the brand name Yervoy, is a monoclonal antibody medication that works to activate the immune system by targeting CTLA-4, a protein receptor that downregulates the immune system. Cytotoxic T lymphocytes, CTLs, can recognize and destroy cancer cells. However, an inhibitory mechanism interrupts this destruction. Ipilimumab turns off this inhibitory mechanism and boosts the body's immune response against cancer cells. Nivolumab is a human monoclonal antibody that blocks PD-1. It is a type of immunotherapy and works as a checkpoint inhibitor, blocking a signal that prevents activation of T cells from attacking the cancer. The most common side effects when used in combination with chemotherapy include peripheral neuropathy, damage to the nerves outside of the brain and spinal cord, nausea, fatigue, diarrhea, vomiting, decreased appetite, abdominal pain, constipation and musculoskeletal pain. Provenge is the first FDA-approved immunotherapy using the patient's own immune system to fight advanced prostate cancer. Studies suggest that men who receive Provenge when their prostate-specific antigen level is lower and live longer. The proliferation of prostate cells produces a prostate-specific antigen, PSA, which elevated level in the blood of men is often an indication of prostate cancer. The use of PSA as a proxy for tumor size, though inaccurate, is often used as a measure of prostate cancer level, both clinically and among mathematical modelers of prostate cancer. The choice of treatment strategies for prostate cancer usually depends on many factors including the stage of the cancer, the patient's current health conditions, and the patient's feelings about the possible side effects from each treatment. Like it is the case for most cancers, early detection and staging of prostate cancer provides important information about the extent of the pathology and anticipated response to treatment. The standard care of metastatic cancer-resistant prostate cancer is androgen deprivation therapy, ADT, which consists of administering hormones that reduce androgen, resulting in slower growth of the cancer. However, patients always develop resistance to ADT and tumor resurgence eventually occurs after a unique timeline of therapy for each patient. ADT in combination with chemotherapy often significantly increases overall survival time in patients with metastatic prostate cancer. More recently, immunotherapy by checkpoint inhibitors has become a powerful new tool in the treatment of myeloma and lung cancer, and is currently used in clinical trials in other cancers, including metastatic castration-resistant prostate cancer. Clinical trials, in increasing number, consider ADT, enzalutamide, ENZ, in combination with cancer vaccine, sipuleucel T, SIP-T, Provenge, and immune checkpoint inhibitors, ICI, particularly for checkpoint CTLA-4, anti-CTLA-4, ipilimumab, and PD-1, anti-PD-1, nivolumab. In the following examples, we fix the dosage for each drug and treat mCRPC accordingly. First, anti-PD-1 alone shows 16.33% efficacy, and anti-CTLA-4 shows 13.59% efficacy. Then we tried the combination of anti-PD-1 and anti-CTLA-4, which resulted in 25.15% efficacy, a slight increase but not a significant one. Then, we observed efficacy with the cancer vaccine, CIP-T, which gave us 2.31% efficacy. The efficacy of cancer vaccine alone with anti-PD-1 is 18.58% and with anti-CTLA-4 is 17.01%, and the combination of all three together is 28.48%. This combo also shows a slight increase in efficacy but cannot be determined as a successful drug combination against prostate cancer. We observe that various combinations without ENZ do not reduce tumor volume significantly. However, combinations with ENZ increase efficacy, from 89.08% with ENZ only to 96.52% with the combination of all the four drugs, anti-PD-1, anti-CTLA-4, ENZ and CIP-T. In particular, the combination of ENZ with anti-PD-1 and anti-CTLA-4 increases efficacy from 89.08% to 94.41%, in agreement with previous data. These simulations, based on mice experiments, suggest that combinations of ADT with CIP-T, or PD-1 and CTLA-4 inhibitors would have much more benefits if we significantly increase the dose of each of these additional drugs. Side effects. We note, however, that PD-1 inhibition is associated with adverse events such as thyroid dysfunction and pneumonitis, and CTLA-4 inhibition is closely associated with colitis and hypophysitis, and both drugs are associated with rash and hepatitis. We also note that CIP-T, Provenge, is associated with rhabdomyolysis and myasthenia gravis, while ADT, ENZ, is associated with ischemic heart disease, hypoesthesia and non-pathologic fractures. This raises the question of determining the maximum dose of an immune checkpoint inhibitor or prostate cancer vaccine which, in combination with ADT, will not cause any of the above adverse events.